right, welcome to Our Experience, the ASCP podcast. I am Chad Wurz, Chief Executive for the American Society of Consultant Pharmacists, alongside my tag team partner, Tom Hansel of Hansel Health. And today we have another ASCP Leading Not Bleeding episode, and it involves Partners HomeMeds. If you remember a few episodes back, we spoke with the founder and president, June Simmons, about Partners HomeMeds. And they've been doing, and I think this is probably something that we don't always consider, but they've been doing something that we feel like is now emerging as one of the leading opportunities for pharmacists and for long-term care pharmacy, and they've been taking care of people in their homes. I think we always think these ideas are new ideas, but people have been not wanting to move on to assisted living, not wanting to move into skilled nursing facilities, and wanting to age in place and age at home for a long time. And Partners HomeMeds has been doing that and using pharmacists to try to help people manage their medications in their home setting. And today we're joined by two of their clinicians, Manoj Mathew, who's a physician, and Sindhu Sahadevan, and she is a pharmacist, and we're going to talk to them about Partners HomeMeds and their practices. So maybe we just start there. We'll start with you, Manoj. Can you just introduce yourself and a little bit about your professional background?
Sure. So aloha, I'm in Hawaii right now, but I'm based in Los Angeles. But as you mentioned, I'm a physician. I'm an internal medicine physician. I say that I grew up in managed care because I started my career in Los Angeles with a company called Healthcare Partners, where we took full risk for commercial and senior members. So I started off as a PCP, but then quickly went into the acute and post-acute care space as a hospitalist and a sniffist. So my career has really been around trying to manage the cost of care, trying to help in terms of population health as far as managing both outpatient and inpatient care. So in that company, I had a lot of great mentors and great opportunities. And when I left after about 13 and a half years, I was a regional medical director. I oversaw group and IP operations for the company. So we had our own clinics with PCPs and specialists, as well as an IPA. And so I oversaw a territory in Los Angeles, but then also the northern part of LA. I oversaw all the inpatient and post-acute care programs. And then subsequently went on to work at another company called Agilon Health, the national medical director there. And that was also focused on taking on full risk and managing patient care, both in the cost of care and coordination of care. Did that for a while and then left, and now I work on different projects and have an operation out here in Hawaii as an IPA. But my clinic, I'm an internal medicine physician, as I said, a hospitalist sniffist. Also, because of the type of work that I was involved in, got into hospice and palliative care, so was boarded there, work with some of those programs, and just all of us. I mean, I think we end up working towards the most vulnerable and high-risk patients and the elderly. And so, Partners in Care Foundation is located just literally walking distance from the hospital that I practiced at, and met June Simmons, who you interviewed a few episodes ago. She's amazing. When I grow up, I want to be June. Like, she is just such a pioneer and visionary. Was privileged when she asked me to join the board. So I've been a board member of Partners in Care for close to a decade now, and for the last couple of years been chair of the HomeMeds program, and just really believe in trying to have a team approach to healthcare, and that includes not just all of the different disciplines within healthcare, but also the social and community-based organizations that can really bring skill sets to the table that we on the healthcare side don't really have as much ability to do. So great to be here. Great to talk to you more about our program and what we think about. So thank you.
That's an awesome experience. I want to ask you just a quick follow-up to that.
Yep.
Because your experience in managed care, and you've this broad experience, there are times when you're talking to pharmacists that work in this space where you're like, listen, we're going to have 19 million more people over the age of 65 in 5 years. I'm not worried. You shouldn't be worried that there isn't going to be enough work. We should be worried about where we're going to get opportunities, because we have to be we have to be able to help. There's just going to be too many people. What do you think I'm not going to ask you for the answer, but what does managed care, when do they sort of tip toward this concept that, hey, we really have to provide these kinds of services to people that are living in their homes? We can't just go on with the old sort of person goes to the pharmacy model, person goes to the physician model that may have worked 5 years ago, 10 years ago, 15 years ago. What gets their attention when they look at these kinds of services and say, yeah, we have to have this?
Yeah, no, it's a great question. We healthcare moves at such a glacial pace, right? It's hard to kind of get change, and in some ways, it's good because we don't just go after the new bright shiny object. So in that way, it's good. But then it also prevents us from engaging and being innovative. But one of the things that I think is driving this is, as I said, we take, I grew up in managed care where we take on full risk. So when the physicians and all of the other team members understand where the upstream and downstream impact is to how we take care of patients, I think that's meaningful, right? When in this kind of model where there's integration, you're able to actually have visibility. For the longest time, as you all know, medications are expensive, but I, as a physician, when I prescribe something, I have no clue how much it costs. I barely know the formulary, right? And somebody has to tell me that's not covered. And so when we start getting more information that allows us to understand the cost, then we participate in trying to manage it better. I think for managed care companies, it all comes down to the bottom line. And so when they start to see how, ignoring these issues such as medication adherence, because that's part of STAR measures and that affects them on their top line revenue. So that's an issue, right? Then when you talk about readmissions and what's avoidable, whether it's 20 to 40% of readmissions in the first 30 days, or whatever study you want to talk about, is related to medications. Like then it's like, oh, you mean I could have prevented that admission that cost me so much money? Well, how do I do that? Well, this is why you bring in people like Sindhu and others to say, hey, well, I can help you because this is my area of expertise. And I think that's starting to resonate more and more. And the last thing I'll say is, when you hear about Medicare now trying to move everybody into some sort of accountable care payment arrangement by 2030, right? Now more people are trying to say, okay, well, if now I'm accountable for this, or there's some sort of shared savings and gain share, then what are those interventions that I can bring to bear that's going to give me good care outcomes that actually translates to good fiscal outcomes?
That's awesome. All right, Cindy, we're going to turn to you. Give us a little bit of your background and how you got here.
Absolutely. Hi, everyone. My name, as Chad mentioned, was Sindhu Sahadevan. I am a pharmacist by training, board certified in geriatrics, and my background actually is in long-term care. So I spent about 9 years practicing clinically with a heavy focus in geriatric psychiatry, but overall just geriatrics. And I, found out about the HomeMeds program primarily because the long-term care facility, or the SNF that I worked at, they partnered with HomeMeds, or partnered with partnered with the HomeMeds platform, or got the licensing for it through a grant funding from I think the Department for the Aging. And so they needed a pharmacist to really help kind of push this or be able to provide this service of reviewing patients in the community, right? Because where I worked previously in Upper Manhattan, there's something called a NORC, naturally occurring retirement communities. And to your point, when people want to age at home, people do not want to go into skilled nursing facilities for long-term care. They want to maintain their independence, and so a lot of times, as people age, they can kind of grow into these naturally occurring retirement communities. And so that was really where the case managers of the facility that I worked at targeted and were able to provide services for. So that was back in 2017. I came on working directly with members of my community, and I actually joined this more as a passion project, and it's just evolved over the years, being able to interact more with partners in care, coming on board, helping to provide training for other pharmacists and other organizations as they, joined into the HomeMeds platform. And so that's how we ended up here.
That's awesome. Follow-up question for you, because that's also like such an interesting path to get to to this point. And, again, I go back to June and being so far ahead of her time, like 25 years ago plus, thinking, hey, we're going to need these kinds of services for people that are older in their homes at a time when that probably wasn't top of mind for a lot of people, is impressive. From your perspective, having your background as well, what do you think the average person doesn't understand about these patients, and what do you see that they might not understand having more of a traditional background in pharmacy?
You will be very surprised how many medications patients end up on, even when they think that they're relatively healthy and able to be independent while living in the community. And it's, working in long-term care, it's not, you would not bat an eye seeing a medication list of 20 plus meds. But the thing is, there are plenty of, older adults in the community that are also on 20 plus meds and, trying to stay in the community.
Yeah, we talk
And
about that. Like, I know that people don't like nursing homes, and they have sort of this public persona that, we don't want to go there, we don't like them. But I always point out, in the nursing home, you have one doctor, you have a consultant pharmacist, you have one pharmacy, you have a nurse. Like, there are things that make it inherently easier to manage your medications. I mean, it's a safe place from that perspective. I mean, we have work to do, certainly, but when you get out into the assisted living that doesn't have those kinds of services, or into the community, there's definitely a lot of risk. And I remember being a consultant going into assisted living where they hadn't had a pharmacist before, and being like, oh my gosh, like, I have to really triage how I talk to the physicians and engage the nurses at those buildings, because ultimately there's so much to do. I have to sort of slow play it into a plan of care. Otherwise I'll overwhelm them and they'll just be resistant. So that's a good comment and observation. I think that resonates.
And I'll add one more. These patients, or these people, because they're people just like you and me.
Yeah,
they're just older. And we're going to get there too.
Yeah, right.
But these are people, you see so many specialists. And a lot of times these specialists might not be a part of the same practice. So you might have a cardiologist that's in one hospital system. You might have a nephrologist that's in another hospital system. You go into a hospital that these doctors don't have privileges in, and people end up getting prescribed so many different things without any crosstalk between all these specialists. And that's kind of one of the biggest problems, that you hear about in pharmacy school, but you don't think it's actually a problem. But when we're doing these reviews and when we're seeing these patients, like, it's true, it is actually happening, and it happens a lot more than we realize that it does.
Absolutely.
Certainly. So we had a chance, like you guys mentioned, to talk to June Simmons and get to know her a little bit and hear a little bit about Partners in Care. But if anybody's listening now and didn't listen to that podcast before, what I was really impressed by, we talked about her being innovative and being a pioneer, but really she took that social care concept and said, hey, we need to kind of bridge that gap, work with pharmacy and kind of bridge that gap to healthcare. And one thing she mentioned was the HomeMeds technology, where really it's about going in and looking at the home environment, right? Looking at the falls and the risks and anything that would be adherent. And we had some good stories. So I encourage people to listen to a few of her stories. They're very, very interesting. But adding that technology together along with the medications, not just what they're currently taking, but getting that history of medications and getting the over-the-counters and the vitamins and all that kind of stuff. Can you guys talk a little bit about that technology and kind of what that HomeMeds software has been able to do?
Absolutely. Manoj, you want to take this one, or?
Yeah, go ahead.
So HomeMeds is a risk assessment platform, right? It's not going to cover every single thing in the book, but what it does take into account is this assessment portion where the person that's going into the patient's home, they're asking them a series of questions, right? Things like, have you had any new onset of dizziness? Have you had, any recent falls, any hospitalizations, things that, are a sign that maybe something could be going on with a person's medication in conjunction with this person has aged and has gotten older. So, physiologically, from that standpoint, our bodies change, right? So medications might affect us differently, but as we age, we don't necessarily realize that. And so, when you're asking these questions, the system cross talks between the list of medications that the case manager or whoever's doing this assessment puts into the system, right? And the platform assesses to see if any of these medications could be related or could trigger an alert because of one of those assessment questions were answered in the positive. And typically, when those alerts are generated, that assessment is sent to the pharmacist for review to see what might be going on. Because an alert that gets generated is more of a foot in the door, right? Just to see, okay, something could be going on. It could be related to the medications. Let's take a deeper look. And oftentimes, that deeper look has led to pharmacists finding a lot of things. Go ahead, Manoj.
No, yeah, I mean, one of the things that I really appreciate about what HomeMeds does is trying to, as we say, have eyes, ears, and feet on the ground within the home. Previously in my previous organization, Healthcare Partners, which is now part of Optum, we had a nurse practitioner program that would go out to the home to go visit discharged patients, again, high-risk patients. One of the things that was really important was, just looking and understanding what's going on in the home, which the community health worker can now do. But looking at those medications was a really important part of trying to get this done. Now, even the nurse practitioner doesn't have the skill sets that somebody like Sindhu does, right? So we're able to do something there. But, it was very expensive to do. To have a nurse practitioner go out to the home, the logistics of trying to manage that was really hard. It's an expensive program to run. It had some value, but how do you sort of scale that? I think what the HomeMeds program and the platform that Sindhu talked about is able to do is it facilitates a much easier way of doing this at less cost, but with probably much more significant value, specifically around pharmacy and medication management. So when you're able to use a community health worker who can come into the home and do the home safety evals, look for food, look for all the social determinants of health that's necessary, right? And have maybe a less intimidating presence for the patient, and then be able to go and look at the medications, grab them, open up cupboards, have conversations, learn about the herbs that are growing outside that they may be taking, things like that. And then providing that in a way that we're able to catalog and document, and then the pharmacists and others can look at it and then be able to sort of make those clinical and sophisticated relationships that I, as a physician, might not understand is going on, either because I'm not aware of it, or as Sindhu mentioned, the siloed nature of healthcare right now, where I believe that patients only on 4 medications, but it's well past polypharmacy at 5, and now they're on 10 and 12. My mother, for example, is somebody I'm trying to do medication management remotely. They live in Houston. My parents live in Houston, and I got to tell you, like, this morning, I got woken up by my mother because there's something going on with the medications, right? Not everybody has a son or a daughter that's in healthcare to be able to call and resource. So I think that we need these tools, and this platform is one part of the overall puzzle to be able to provide that team approach, that care team approach that we're talking about, and leveraging not just the licensed individuals like Sindhu and myself, but really being able to leverage the community in a much more economical way, and to get those insights. And referencing back to the previous question, like, how do you get payers to be able to engage? Part of it is, again, talking about the ROI, but what's interesting, and I think really what's gotten traction, is that the HomeMeds program doesn't rely on expensive licensed clinicians as much as leveraging the community health work. And so, Partners in Care, we're a nonprofit, but so we're able to provide this service at a much lower price point and cost, but have a significant higher ROI. And so I think that's also a tremendous part of why programs like this with community-based organizations can really be successful.
Absolutely.
Yeah, absolutely. Manoj, that type of atmosphere that you guys have created at Partners really empowers that patient as well. They can now speak for themselves. You're asking them, questions that maybe a primary care physician in a quick visit wouldn't even think to ask, and that kind of opens it up. Can you talk a little bit more about just how that empowers that patient and creates advocacy for them, gives them a voice?
Sure. So, I think it's, I don't think we realize how intimidating the healthcare system can be, for those of us who aren't part of it, and even for people who are part of it, right? I mean, I've been in scenarios where, as much as I believe I have an understanding of things, there are certain situations where I am completely lost, right? So when you talk about this from a layperson standpoint, especially someone who is, older, may not have the same faculties as they used to, then I think it becomes that much more important to make sure that they have a voice and are able to ask those questions. I think June gave that example in her in her interview, where they talked about the patient that was demonstrated how to give insulin through an orange, right?
Orange,
Yeah.
yeah.
So you think about it, that's kind of funny, but it's actually sad, right? So
Right.
we, as a healthcare organization, failed that patient, right? We didn't communicate the way we should have, and so you need time, and so the patient probably, they were intimidated, or they didn't understand. There's a flood of information, right? So when you again have these individuals that are not that are from the community going out, having sort of kitchen table conversations. Literally, that's what happens, right? They sit at the kitchen table, bring the meds, they have conversations. They probably are from that neighborhood and maybe can even talk about it. So when you have that level of connection, and then the walls come down, that the patient can ask those questions that they may be really shy or embarrassed to ask in front of the physician or other caregiver, right? And so then we're able to avoid a lot of those problems. And I think agency, like when you're a senior and let's say you've lost your ability to drive yourself, I mean, you start to lose independence, you start to lose your own agency, and you feel less than. And so in healthcare, you cannot feel like you can't advocate for yourself. And I think by removing that, Sindhu's great, but I'm sure they'll probably feel intimidated in front of Sindhu, right? But if you have a community health worker that comes out and can actually start the conversation, I think this gives them a little bit more sense of independence to be able to ask and get the help they need.
Yeah, I think that's one of the things that, again, when people come up with what they think are new ideas, or they feel like there's a new opportunity, and I'll use the pharmacies that, the long-term care pharmacies, they're used to being experts at packaging and logistics and how to store and handle medications. They have consultant pharmacists that do med regimen reviews in nursing homes. They've got all this down, but that environment is it's almost a sterile environment. It's almost an environment built for those services to be successful. When you walk into somebody's house, I have to believe you see things that you might not have ever expected to see, whether, the person is a hoarder, or God only knows what probably some of your community health workers have walked into. And you brought up a good example of the orange. I'm sure everybody involved in training that person to use their insulin was like, we nailed it. This guy, he knows how to do it. And, he didn't. And it was, the completely missed the target. I have to believe the people that walk into the homes and have those conversations, and that have to be the kind of person that individual can open up to, have seen some really crazy things. And that's probably where a lot of the good outcomes come from, is finding that and being able to see that and making the link between, okay, we missed the mark on educating this person and training them on their insulin, but now we're here. Now we've seen what's going on. Now we can fix it. Now I can grab the right resources to fix it. What have you seen, Sindhu, in your practice from that outcome perspective? Obviously you're a pharmacist, you make great recommendations, you help people manage their meds, but there have to be these great stories of, wow, we saw this and we were able to fix it, and it had this tremendous impact on this person's life. Like, what are the outcomes that you've seen working there?
Definitely a lot. And I'm going to add on your previous question to Manoj as well, because it's, even in addition to education, reminding patients that their health is their health. And again, to your point, that they should be advocating for it, because the amount of times that I've spoken to patients to, educate them that the symptoms that they're feeling might not be normal, that they should be talking to their doctor about what these are. Some of the responses that I've gotten, especially in my seniors, their responses are, oh, I don't want to trouble the doctor, or, oh, I thought dizziness was just a normal part of growing older. Like, this is what everyone feels, so this is normal. It's like, no, it doesn't have to be normal. Something could be going on. You should feel empowered to talk to your doctor, because that's what your doctor is there for, right? And pursuant to that, one of the things that I'm always reminded of is when I was first starting with HomeMeds, probably one of my earlier patients, and he was actually some level of a psychiatric patient. I remember him being on 2 antipsychotics, and I mentioned those assessment questions. He had been a recent frequent faller. And I remember taking a look at his medications, the assessment questions. He had had like 2 or 3 falls recently, and he had written that the most recent fall had been because his legs kicked out from under him. And this was years ago. This was probably around 2018 or 2019. And so he had been on, and I remember this really vividly, because I remember thinking, why are you on 2 low-dose antipsychotics? He seemed like he was relatively with it. I don't remember the diagnosis off the top of my head, not that it matters, but he was on Abilify, he was on Seroquel, and I remember calling him to counsel him on the fall itself. And he was actually on Cogentin, if I remember correctly. And especially with older patients who are on drugs like antipsychotics, you have to be very sensitive to the way that you word your recommendations, the way that you're counseling them, because you never want to connect a symptom that they might be having with the medication, because it's very easy for them to turn around and stop that medication. And especially in a psychiatric population, that's not what you want to do. And I remember asking him, if his legs kicking out from under him was a normal occurrence, if he had any other kind of unusual movements. And I think I ended up spending almost 30 or 40 minutes on the phone with him, just telling him, it's really important that you tell your doctor that this is happening. This is something new. Like, speak to them, because they can help you. They can figure out what's going on, and they're, one of the medications, and I did kind of point out the Cogentin, might not be the best option for him based on all of the things that he was taking, but it was a conversation that he needed to have with his doctor. And essentially that was it. And I hadn't actually followed up with that patient until almost 6 months or even a year later, when the case managers had gone back to see him. And I remember calling him on that second time, and he remembered me. It might have been 6 months. He remembered me, and he was like, I'm really glad that you told me to talk to my doctor, because, I haven't fallen. They gave me something different, and they also cut back one of the medications that he was on. And it turned out, I think it might have been from a recent hospitalization that the Seroquel got added, but they knocked that back. They ended up putting him on something for TD, and he ended up not having any recent falls after that. And I was, it had surprised me that he had the wherewithal to remember that I had called him 6 months ago and had that conversation, and that he was able to emote back to me the changes that he experienced as a result of that call.
So let me dig into that a little bit, because this is really a question for both of you, but and this again kind of pulls us back to that whole managed care sort of piece to this. It feels like over my career, which is 25 plus years long, that the industrialization of healthcare has been, we want you to fill more scripts if you're a pharmacy. We want you to see more patients if you're a doctor. We've stripped out the opportunity, A, to build a relationship with your patient, and B, to have enough time to have those conversations. What HomeMeds, Partners in HomeMeds seems to have accomplished, scraping and clawing and kind of rebuilding the structure, is created the opportunity to have at least the perception of more time with the individual, because you're using community health workers, you're you have a good system of identifying and escalating problems, and you're bringing in the physician and the pharmacist at times where they can spend a little bit more time and delve into the issue. I mean, is that part of the secret to this success? Is this part of the way we should all be looking at healthcare going forward? Is how do we build more meaningful, I don't want to say, I guess, meaningful relationships with patients so that we get this back and forth and are able to help them? It's always the profound question. Sorry.
Yeah.
I was waiting for Sindhu to go, but
No, go first. I'll add.
It is really sad because healthcare has changed, and I started practicing back when I was in 2000, and so I've seen the changes as well. And to your point, like there's been it's interesting, right? So you've got the fee-for-service medicine, which is very transactional, right? Okay,
Yep.
so I do something for you, somebody's going to pay me, and it's all about documentation and how sick I think you are. I can make your UTI into like near sepsis on a 5-page note, and I get a level 5 return. Like it's that's sort of unfortunately how the business of medicine works in certain practices. And then to your point, it's about pharmacies trying to fill prescriptions. Like medicine, unfortunately, is a business, right? It's a business of healthcare, and so we have kind of moved away. Not intentionally. I mean, I think a lot of us started in healthcare because we had a true desire to be part of a compassionate, helpful, system where we're caring for our brothers and sisters, right? My mom is a registered nurse, and so the reason I became a physician. I don't know if it's because I'm Indian and it's sort of put into you when you're born. But anyway, I'm going to say it's because my mom would come home and talk about all the good that she did, right? Help these patients. And so that's what you go into. And then, but unfortunately, the system is set up in such a way that you're not able to actually provide that same level of compassionate care in the time that you're allotted. And so we're forced to bring these kind of solutions in because back in the day, your primary care physician saw you in his or her office, maybe came and saw you at home, but also saw you in the hospital, right?
Yep.
Then it became to the point where, I don't get paid to come to the home anymore, so I'm just going to see you in the office and in the hospital. And then it became, I don't have time to go to the hospital, or the hospital medicine is so complicated, or I can't remember the passcode to my EMR over there, and I don't like their Epic EMR, so I'm just going to stay in the clinic. So all this happened, right? So now you've become sort of within your own space where their healthcare is so much broader, but I, as a physician, can only practice within the walls of my clinic, right? And so what we're doing in terms of HomeMeds is trying to give that now expanded care team, both on the hospital and the PCP side, the hospital side, the medical directors at the health plans, visibility into what's really happening at the home, because in the few minutes that they're at the office, you do not get a picture of that patient, and now you got to go to the home, right? So these are additional, tools that we're bringing to bear because medicine has kind of evolved in such a way that we're isolated, we're transactional. And so to your point, maybe the community health worker can try and bring back that level of connection and relationship that can meaningfully make a difference, because we've sort of lost that opportunity. That's really, I'm sorry, that was very pessimistic. Wasn't it really dark?
No, but like, I think that's where, I mean, if you are a compassionate healthcare worker, that's where you go. Like, it is dark.
And it's just in time too, because our population's never been larger, and our population for geriatrics is going to be worldwide record setting, as far as that population goes. So, this is essential because, again, we already have 54 million people. 50 million of those are living at home.
Yeah.
And what I was going to add, I think, it's probably just as pessimistic as your thoughts, because my comment was going to be that, as healthcare has evolved and become this almost, gone down this mechanistic route, it's almost like all of our patients have kind of a good amount of our patients have fallen through the cracks. And, I think HomeMeds tries to address this and really serve almost as a bridge for these patients to bring them back into to serve them, right? To almost be like a placeholder, a reminder that they're still there, they still matter, what's going on with them still matters, and we want to help keep them, at the forefront of this story, right? These are the patients that we're doing this for. And trying to build a better system for them, because like I said before at the beginning of this call, this is our future, and the only way to make it better is to start now and put in the work, so that, and maybe this is selfish of me for saying it, but when we get there,
right.
My hope is that it is better.
And I see your pessimism. I'll be the optimist and be like, that's why you're here. That's why we're talking to you. That's why it's so interesting, because and maybe it's the nonprofit model. Maybe it's, just the pioneering spirit that led to this starting so long ago, and all of that experience now informing how you do it today. But this is the model. Like, this is the model. When Manoj said that it was full risk, I'm like, when we look around, it's the PACE environments that we're like, okay, it's the best version that we've got. It may not be perfect, but it's the best version that we've got, because there aren't the restrictions that we see in the fee-for-service model or the traditional model.
Yeah.
You're able to do what you need to do for that individual, which is ultimately, I think, what we all strive to do as clinicians taking care of people, whether that's a family member or one of our patients. It's, I'm going to get you what you need. If you need that expensive medication, I understand that, but if that's the only one that's going to work for you, I've got to find a way to get it for you. Otherwise, we're going to fail. And failure is hospitalization and, ultimately potentially death. So I want to get you the right thing. So I think we're getting there. Like, I do think we're arguably on the road, Sindhu, of getting to where we need to go, so that when we get there, it'll be in a better place. I don't know if it'll be good, but it'll be a better place than it is today. So I'll be positive from that standpoint.
So maybe I can bring a little light to the darkness I started this off with, but so the capitation and the full risk, right? So that financial driver, right? So when you talk about sort of the transactional medicine of fee for service, and physicians, unfortunately, they're private practice, they're running a small business, right? They're hiring, they're firing, they're worried if the receptionist who's got a new baby is going to come in because the baby's sick, right? They're doing that on the business side, and then they got to actually practice medicine, right? And so they have to think through how the patient is going to respond, and then are there no shows? Like, there's all of that going on, right? So one of the things that I appreciate about my career is being within the environment that I practiced in, that kind of where the physician, right, where I'm responsible for that dollar, right? I'm in the medical group, I'm delegated, I'm full risk. I'm able to figure out and determine where I spend that dollar, right? If I can save money appropriately by avoiding admissions, and no patient wants to be admitted, right?
No, right.
Unless they need to, right? And everyone wants preventive care. So if I'm focusing on preventive care, there's more money left over, or I can allocate money for social workers, right? We had clinical pharmacists that were amazing back, 20 plus years ago, to help us manage these patients, because we knew that we were not the experts in terms of all the possibilities, right? And so that type of team approach, working with, our partners on the pharmacy side, working with clinical social workers, that was something that we started back 20 plus years ago, because it was the right thing to do. And we didn't really worry about, well, is there a CPT code for this? Is there, where do we send the bill for this, a claim, right? Because it was us, and we hired, or we paid, or we had invoices. So this program that we have with partners, right? So when we started out, we were able to work with certain health plans and say, hey, listen, we think that this is meaningful. Let's have a contract with you, and you guys pay us a case rate, and we'll manage this, right? So this is where hopefully some amount of value is brought by organizations on the community side that typically didn't have the ability to penetrate into this healthcare ecosystem as far as the billing and collection standpoint, right? So this is sort of outside of what typically Medicare A, B, and C and D pay for, right? So now that the dollars are sitting with the groups that actually are able to make those decisions, and this is where programs like Partners in Care and HomeMeds are able to kind of say, hey, listen, hello, we can do this for you. Guess what? We can do it cheaper and better. Yep. And so that's kind of where, as you mentioned earlier, we fit in. But that's where also sort of the changes in healthcare are driving clinicians and healthcare executives to think about things a little more holistically rather than the narrow way that we used to think about healthcare, specifically around patient engagement only at a clinician level that got reimbursed. And now we're able to look at it from a care team model. We got PCPs that don't try and stuff as many patients in because they're trying to maximize RVUs. They're actually trying to manage a panel of patients.
No, that's awesome. That's exactly right. I mean, we could talk forever, I think, on the model. Again, I brought up the fact that this is a nonprofit for a reason, and that is not so much that you don't make money, because without margin, there's no mission. You do. But the reality is, I think that's where some of the traditional managed care is gotten a little sideways, is that they look at capitation and they go, I want to make as much of that as I can. So how do I make as much of that as I can, as opposed to how do I deliver the best care and leave a reasonable amount of profit for my business? And I think, this is my opinion, but nonprofits do that a little bit better than I think for-profits. And that's kind of the environment we're in. You also worry that the for-profit groups cherry pick, like, well, let's go after all the relatively healthy people so that we can not spend as much of our capitated dollars because they're generally healthier, instead of really attacking a population holistically and taking the good and the bad and really working to have quality healthcare be the metric that drives the business.
Yeah.
I mean,
Go ahead, Tom.
I was just going to say, Partners is really making it a patient-centric model. It's a relationship model, and that's what healthcare and all we clinicians went to do was about the patient. So you're really putting that patient right back in the center and not making it a volume based, which our government has turned into, but a patient-centric relationship, listening and hearing what's going on with that patient. And there's only one outcome of that, which is going to be a positive one.
Yeah, and it's a lean back to a knowledge-based practice versus an information-based practice. We talk about interoperability. We talk about getting the information from the hospital at the nursing home, or from the physician to the hospital. And the thing that you can't transfer is knowledge and relationship about an individual patient, how they store their medications in their house. They're a second shift worker. How does that impact the care that they are on and how they accomplish what they need to accomplish with their medications? And that's what feels like Partners in Care and HomeMeds is doing, is sort of creating a knowledge base around a person that feeds that, so that you do know, hey, by the way, this person's a second shift person. By the way, this person stores their medications this way at their house. Like, these are things to consider when we add a new drug, or that we look at a problem that may have occurred with them. And that's different than I think we've seen in healthcare in the past couple decades. And we applaud that. I think that's great. So any final thoughts from either of you on just what your experience has been, where you see the future of healthcare as it relates to people?
So I am actually somewhat optimistic. Man, I gotta like defend myself. I'm not myself.
I love it.
I am optimistic in a few things, right? So I do think that tech-enabled healthcare will make us better. I think there's a huge shortage of clinicians in general, and we need to be able to somehow fill that gap. I think technology will be helpful, and I think this type of population health will kind of make sure that programs like Partners in Care and other HomeMeds are going to be utilized more. And to that end, I will, as a board member of Partners and the chair of the program, I will say that, we are so grateful for people like Sindhu who saw the program and thought this was a great idea and participated. So to your audience, I will plead that, hey, if any of you experts out there in pharmacology are willing to kind of participate and want to learn more, we'd love to send you more information, because we need your expertise to be able to make things like this successful. But that's the kind of collaboration that I'm optimistic about, right? Being able to kind of have programs like this will hopefully make a difference. And then when we get older and we want to age in place, that there'll be the Optimus Tesla robot with all this knowledge that's going to make sure that my medications are given to me in a timely manner.
There you go.
Yep.
Sindhu?
Especially if you could do that at the beaches of Hawaii, right?
Exactly.
All over the world, because I'm going to add to that optimism, because like I said, I'm doing this work because I believe in it, because it is a passion of mine. And also, if I'm passionate about it and I'm doing this, I know that there has to be other people out there who have that passion and who want to be able to do this work as well. And so, as it pertains to HomeMeds, I do believe with as technology grows, as we evolve this program and other programs like this, being able to get on board and contribute to these will help make healthcare improve over time. And hopefully when we get to that point, it'll be better for us too. But that being said, for anyone who does have interest, I hope you can always contact us at Partners in Care Foundation. I think it's picf.org. There is a contact us button on there, and I believe that we'll be at ASCP next month.
Yep, in Denver.
I think
Yep.
we have a booth. So
Absolutely.
definitely stop by, say hello, say hi, make a friend.
Awesome.
And we'll have plenty of information if you have interest in learning more.
Awesome. Well, thank you both. You're both leaders in healthcare. You're both helping us look toward a better future for healthcare and doing some groundbreaking work, which oddly enough you've been doing and Partners in Care have been doing for 25 years. I think healthcare has caught up to where you guys have already embarked, and I see a bright future for pharmacists, and I see a bright future for patients that live at home with these kinds of services. So thank you for being on the podcast. Today's discussion highlighted the critical role of comprehensive medication reviews and screenings in improved patient healthcare outcomes. For more information on how to connect with Partners in Care Foundation HomeMeds program, please email homemeds@picf.org or visit www.picf.org/HomeMeds. Thank you both for being here. It was great.
Thank you so much for having us.
Thank you, guys.
Take care.
We'll see you next time on the
Aloha.
next podcast of Our Experience.